Welcome back. We're going to jump into our final combined breakout discussion. I want to thank everyone for hanging with us through the course of this, and some of our colleagues have had to move on to other events. We want to thank them for the contribution as well. This has been a very, very provocative 2 days, and now we have to have the mental energy to capture on paper what we think the conclusions are and what we think the action plans are, because this is not a workshop for talking, this is a workshop for doing. So with that, I want to move over to Dr. Yankelevitz, who's going to kick us off on the first breakout.
Okay. So I headed up the clinical breakout session, and slides are going to be shown for me. I sent them. Do I share my screen or something, or how are we doing this, Liz?
Liz, you're muted.
I have them, Dr. Yankelevitz, but I was also told that you could share them if you wanted to.
It doesn't matter.
If you can post them, that'd be great.
Put them up, that's fine. Okay, so the title of the session was Data Use at the Time of Screening and AI, Defining Consensus, Value, Context, and Responsibilities. And I first have to thank my co-leader, who was silent in this but took notes and prepared the slides, Rowena Yip, and did a great job for us as usual. We call her the secret weapon in LCAP. Next slide. So we started off with this set of questions, but it was really revolving around the idea of, should we make a very large database available to the world in a much more accessible way? And we had these 6 questions that we were sort of thinking about. And I'll go through each of the responses to these questions as we move through this. Next slide. And this is with a view towards big data, and we were sort of discussing what should if we were to start doing this, what would the purpose be? Would it be for lung screening primarily, or would it be for other things primarily? And as we had a lot of discussion in the whole meeting, we started realizing that it would not be reasonable to just make it focusing on lung cancer. You'd rather make it all as broad as possible. And perhaps the biggest value is ultimately going to come from this concept of general health, which it just seems to be moving more and more towards as we do this lung cancer screening. And in fact, we're seeing that probably the biggest bang that will ultimately come from this, from what we're calling today lung cancer screening, will probably be from several of the other areas that we're evaluating. We'll get more value out of. And we were just talking, LCAP has been around for a long time, and we've published, some 300 odd papers over the years. And if you look at the trend and what the papers are, it's gradually moved away from the screening itself. More and more papers are being published in the other things that we're finding and other areas that we're doing. And I think it's evolving that way in general. I think much of the work we see now from other groups is on all of the other findings, which I don't like to call incidental findings because they're more important, and maybe bonus findings is a better word. But I think so. So the idea is that it should focus broadly. And one of the topics that came up in the keynote speech, which I thought was outstanding, was even this idea of muscle mass and muscle density. And, and I think this is just going to be another wide open area, which is going to ultimately have a lot of value in terms of providing information about general health and things that we can do with these larger databases. Next slide. So let's just assume an infrastructure exists for supporting the data, curating, monitoring, and releasing it. What are the challenges in using it and putting it together? Well, there are some existing resources out there for this. Certainly there's large databases like LCAP, which has 250,000 scans in it. MIDRIC is doing something not with lung cancer screening, but they are doing this kind of idea of putting these databases together. They're doing it in other areas, and I know they've looked at a lot of the challenges that I will talk about ultimately. You can think of an organization like GoTo Foundation, which has 800 centers of excellence. And, this is a big resource that's out there if we wanted to start thinking about making a database. I neglected to mention here, and I should have put it in, was ELIC. ELIC is doing something similar. They're starting to collect databases, and they've built an infrastructure that's an important one, as ISLC is another organization that's involved in this area. And similarly, the VA is starting to get into this area. We just listed some of the challenges in creating these kind of databases. There's no uniform way for data collection. Each group and institution have different policies on how they want to share data and what restrictions they want to put on the data. This was a part of the discussion yesterday in one of the sessions. Heather Pierce and Eric Liam were talking about the sort of the inherent challenges that institutions face in terms of how they want to release data, how easy it is to release it. And these are some of the things that, I think there's a lot of work that can be done in terms of who can use the data. Also, the need for critical information beyond CT images came up. What information are we going to link to it? Surely there's some value in just having images, but I think a lot of the value comes from the information that we can link up to it, medical history, physical and diagnostic, and places like the VA in many ways are way ahead. They have their Million Veteran program where they've taken bloods and done a substantial genetic analysis on these people, on 1 million people that they can potentially link to screening data. So this is where a lot of the power is going to come. And how do we reach out to all the screening sites that are there, especially in regard for the issues of equity and getting these varied populations? We don't just want a uniform database. We really want to be very, very inclusive if we want to do things, especially when you start thinking about things like establishing normal values and what are the type of things that we can do. Normal values are going to be different in different subpopulations. And this was a point that we were really stressing. Dr. Teoli brought out that we're just learning, for example, that in the African American community, the normal value for white blood cells is now different. They're realizing that the normal values are different. And we've seen, this in other areas, EGFR, for example, different values are established. I'm convinced that several of the things that we're going to be measuring on CT scanning, whether it's osteoporosis or even liver, or possibly even, for all I know, lung density, may be different in different subpopulations. So we need a very inclusive database if we're going to really start getting at these areas. Next slide. Some of the areas that we were thinking of doing, and Bruce Pyenson brought out that it would be wonderful to work with somebody like Medicare and be able to link the Medicare data to some of the findings here. Certainly that'll give you a lot of demographics, but it'll give you other information about people, what they've had. In the COPD world, you'll learn whether there are exacerbations or not. Things like that you can start to get at. And SEER database has links to many other areas as well. We did speak, Drew Moganaki was very positive on the idea of being able to collaborate with the VA, and that the VA is either going to do something like this or be willing to collaborate in providing data and making data available that could be in some very large database that could be accessible outside of the VA as well. So these are, I think, very positive statements. Next. The issue of how to collect data, whether we just get a big database and sort of put it in there and that's it, or whether we really start to think about these sort of living databases where you're continuously collecting on an ongoing basis. It has an obvious advantage in doing that, and that is it keeps up with technology. And that's really what you want to do. The NLST is a wonderful release. That's just a spectacular resource that's available now, and they've actually just opened it up even more. But the data in the NLST, by today's standards, is kind of obsolete. It's 2.5 millimeter slice thicknesses. people who are doing cutting edge work now, and the software that's going to really change the world is not going to come from that database. You're going to need the highest resolution scans. I'm afraid to use that word these days. The highest resolution scans, or the most up to date, to do the type of advanced image processing and analysis that will do it. Now, the problem with a database like that keeps up and continuously collects is that the biggest challenge now is not so much in getting the data. There's a lot of data, and we could set up a system that collects it. The problem with using that data is the data cleaning or data cleansing. That's the biggest challenge, to make sure that you're getting data in that's good. And that's going to be, I think, the biggest challenge with developing. But in a certain sense, that requires you can minimize the data cleaning if you're collecting it in a very, very standardized way. If you have comprehensive data forms, there's lots of checks that can be done on the data, both from the quality of the image data itself to the quality of the metadata that you collect around it. And all of that's going to be very important if we want to really do this kind of database that's going to be evolving. And then you can even think of setting up normal values that are evolving almost on a continuous basis as well. Next slide, please. Yeah, I was just reminded that wouldn't it be wonderful if we had standardized smoking histories that we could collect? That's gives you an idea of how challenging it is in terms of the data cleansing. Even that can be a challenge. Control of what data is used and by whom. This is a big issue. We had Heather Pierce, who represented the AAMC, giving a talk, or I should say participating in the panel yesterday, something that they're really starting to think about. And the issue, there's a little bit of I don't know if it's the right word, a tension between what the academic institutions might want in terms of their ability or desire to release data versus what people may want their data to be used for versus what perhaps industry and society might want data to be used for. So all of this needs to be navigated. And I think it's very, very important. But who should have access to this data? I mean, in my view, ultimately, the biggest innovations will come from these smaller companies that are out there that are really starting to do innovative stuff with data. And I think it'd be wonderful. It would just speed up their development if they could have easy access to potentially free or near free data. That would accelerate the development, because these startup companies spend half their dollars trying to find a database. And if we could speed that up, that would be fantastic. You would really change the way a lot of these, and not just small companies, even medium and big companies need it as well. So I shouldn't be meaning that it only affects the small. It affects all. It goes all the way through. And I think, especially in imaging, it's something because the resource is reusable. It's not like a blood sample where you use it and you kind of lose it. Here, it's a reusable resource. We then talked about how this could be done. Well, certainly, possibly through the NIH, and MIDRC is sort of going down this path and doing it in some areas. I think that's certainly an option. Other organizations outside of NIH could be thought of. In a sense, NIH you think of as research. It was brought up to me that agencies like AHRQ, which are not research, they're more implementation, might be even a more appropriate area for this, or the National Library of Medicine, Corey, yeah, I mean, lots of places to think about how this could be done. Even just a completely independent organization that comes together potentially could do this. And I think a lot of people would be interested in participating, a lot of organizations. The cost of this, I think in fact, the infrastructure from the computer point of view is probably the least expensive aspect of this. Major investment is coordination, oversight, contractual agreements, and sort of data cleansing and monitoring. I think that's where the big cost in this is, but I think I think that can certainly be scoped out. And for the potential value that this has, it would, I think, dramatically accelerate development in these areas. Next. How would we measure the success of something like this? Interestingly, Heather Pierce was talking about the idea yesterday of how we judge institutions that give data, or investigators that share their data. And she said, people should be given a benefit by, if they share their data to the public and it's used, that's really, it shouldn't just be the number of publications they have that a person has, but if they've shared their data and it's really useful to others to use it, that the number of groups that cite their data or use their data to make their own publications or other developments, that's a measure of success. Imagine if we had a database and it was released, and some small software company built a product that changes the way we do things. That's a tremendous measure of success. I think those are the things that we would potentially want to track to show that something like this would be successful. Next. Who would support this? Interesting. I think there's potentially a lot of sources. Obviously some major organizations, or governmental organizations potentially could do this. I think that there's a lot of opportunity for something like this philanthropically, and I know that I'm personally interested in reaching out to donors that I know, that to see if this is something they'd be interested in doing. I think that we would need to start scoping things out a bit in terms of cost and whatnot. And I think we would be able to get a lot of organizations that get behind this in terms of doing it. And we're here today with Prevent Cancer Foundation, GoTo Foundation, American Lung Association, Kiba. I should put ISLC probably on this list as well. I think this is something that's, I don't want to say apple pie because it's more a global kind of thing. But I think a lot of groups would really be supportive of this. And I really think it could accelerate development in the areas that we're all the whole group here that's participating thinks is important. Next, I think that was it. Yep. Okay. I'm set, Jim.
Okay, great. That's very helpful.
David, thank you very much. That was great. I think it might be good if anybody has any burning questions, comments, thoughts around this session. Let's take a couple of minutes to talk about this session. Then we'll have we'll have Rick Avila present this next session, and then we'll have a little brief discussion just about that. And then we'll conclude with a integrated discussion about both sessions.
Jim, could I make, sorry, you were going to say something more?
No.
Just on David's presentation, I think it's important. Sorry, starting my video here. I think it's important to discuss open science and open source. So just to give a little history here, there is this VA PALS LCAP lung cancer screening management system based on LCAP that's running in the VA right now. And that's an open source project with a data dictionary based on the LCAP experience. And it turns out that the IASLC's ELIC, Early Lung Imaging Confederation project, which is a federated database, that uses the data dictionary of VA PALS LCAP. And anybody in the world can get hold of the data dictionary. And we encourage people to do so because, as David said, it's just a really hard thing to try to harmonize and get everybody's lung cancer screening data with the same definition of pack years, with the same definition of other things. So anyway, I just want to point that out, David.
Yeah,
thanks, Rick.
Yeah, that'd be great. So I would say is if we could ask Claudia Henschke, whoever, to write an article and have that whole data dictionary hosted as a supplement to that, and it could get out and around, that might facilitate that. And if there's any problem, I think I could find some places that would be delighted to do that type of thing. Okay, yeah. So there's more deep dive we have to do on that issue, but I think it's a great concept. Claudia, can you talk? Okay, I'm sorry. Okay, any other questions about what David just presented in a synopsis for the data session? I don't see any. The chat's free, question and answer is free. So Rick, let's move on to the second breakout.
Great. All
Thank you.
right. So I'll share my screen. So you can see this PowerPoint presentation, right? Yes? I'm going to assume that's a yes. Nobody's saying anything.
Yes, yes, yes. See your
Sure.
screen.
Okay.
I can see it too.
So we just have a couple slides here. The first one is on CT image quality and a concept that's come up a couple times in the meeting. This is the concept that 3D accepted 3D resolution standards do not exist for CT. And I'm just showing you a couple things that we kind of focused on, and that is the IAEA guidance that there are no general international standards for measuring the MTF, which is a way of measuring resolution of CT scanners, has been implemented yet. And that only measures 2D resolution. And what we want is 3D resolution, and we want it through the whole field of view with large sampling distances and other things. And it's also important to point out that every scanner vendor that currently exists right now has their own unique set of CT image quality phantoms and software methods for analyzing those. So after 50 years of development of CT, we unfortunately don't have a resolution standard. For quantitative imaging, that's a really big deal. So as a group, we recommended the following, that a multidisciplinary group of engineers, scientists, physicians, and others from industry, academia, and government develops a 3D resolution measurement standard that works accurately at multiple locations across a full CT scanner field of view, which is about 50 centimeters. Ideally, this will be an open science, collaborative, constructive, data-driven, and pragmatic initiative with the additional goals of setting a low-cost and easy-to-use 3D resolution measurement standard designed to be internationally accepted. So no small task, but it's our recommendation as a group, as a technical group, to request that the field move in this direction. Secondly, we understand that you can't just ask for something, you have to justify it. So a study or a clinical trial showing that the benefits of being able to monitor and control 3D resolution and other image quality metrics would help motivate the field to adopt and use this new standard. Modeling and simulation with existing CT image quality data can help identify the importance of maintaining high image quality for CT lung studies. So again, this is coming back to the idea that we have to prove, at least with some data, and it can be modeling and simulation, at least for some things, that this would have a benefit to, let's say, early lung cancer detection, volumetric change measurement, emphysema measurement, emphysema over time measurement, things like that. And with the ultimate goal here of being able to demonstrate that these image quality controls that we're discussing here will lead to improved clinical actions, and I would even also add personally outcomes. So that's our first recommendation. It's on this need to have a 3D resolution measurement standard. Now I'll move on to the second area that we looked at. So, and remember that we made all of these recommendations before our session. So, so there's probably some things we could have added had we been able to travel in time. But since that wasn't the case, here they are. So the best quote award goes to George Washko from the Technical Breakout Group. And that is, our failure to establish a standard is the reason we do not have a therapy. And that kind of resonated. And I think I'll ask George, do you want to give some texture to that quote?
George is not in the session, Rick.
Well, that's going to be hard, isn't it? Okay. Well, I think he was getting at that basically for lung density, the lack of standards, probably just on protocols. I don't know if he also meant resolution, but let's say protocols is a major contribution to not making advancements in therapy, which is a big statement. Javier and George were the co-moderators of this. Javier, do you have anything more to add to that quote?
No, you paraphrased it almost perfect.
Almost, okay. All right, so moving on. Our recommendation is that low-dose CT imaging guidelines are developed that support early detection of lung cancer, as well as quantitative measurement and change measurement of suspicious lung nodules. Then correspondingly, early detection of emphysema, and as well as quantitative measurement and change measurement of emphysema. That seemed to be, from our group, the main area that we thought the scope of this guidance document should be. It was pointed out by one of our pulmonologists that guidelines will need to be considered. We'll need to consider that there are several different forms of emphysema, including central lobular, panlobular, and paraseptal. I remember a long time ago, I got a chance when I was at GE working closely with CT to look at some very high resolution CT of I think it was pig lungs, and we could see the interlobular septa and other things. So maybe one day we'll be able to distinguish these a bit better. But yes, it would be good to consider that for these guidelines. It was also pointed out that visual observation of emphysema has been associated with lung cancer risk. And as Chuck Hatt very nicely covered in his presentation, quantitative methods have not been as successful, but maybe calibrated quantitative methods. Well, it looks like calibrated quantitative methods will do much better. Therefore, perhaps a long-term goal of quantitatively measuring emphysema in low-dose lung cancer screening scans is to help establish a lung cancer risk score that's quantitative. And the low-dose CT lung cancer screening and emphysema scoring scan should be performed at full inspiration. That will help with measurement of lung nodules over time, as well as with emphysema measurement. And then finally, we should also consider support for other diseases like interstitial lung disease, bronchiectasis, and I'm sure there's a long list after that, in addition to emphysema. So that covers our recommendations. Are there any questions or comments?
So I have a comment. I wanted to go back to your first recommendation, and I really kind of urge the group to pursue this. You know, I think about where CT is heading. And, these quantitative measurements are really where a lot of the action is now in CT. And it's certainly in the area of CT screening, but in other areas as well. And I get very nervous when I hear things that the CT vendors each have their own calibration devices, and each one measures it their own way. It's, once you let industry kind of take control of that critical aspect, it has a way of leading to problems. I think some outside standard needs to be set up. You just don't let it, we've seen this in the automobile industry. We've seen this in the airline industry. I mean, this is what CT scanners are doing now. This is the coin of the realm. The idea of being able to measure things accurately. And we just can't let them set their own standards for how they're going to measure it with their own calibration devices. I think, yes, there are standard ones that are out there, but they're not being used necessarily in standardized ways. So I think, a powerful statement from a group like this would really start to generate something. When I see the International Atomic Energy Association saying there's no good measure of resolution on a CT scanner, that's really shocking. That's really shocking. I mean, that's what CT scanners do now. That's what we're all saying to use it for. So I think this is a major goal for this group to pursue, and get the right people to help, draft something would be very powerful. So I'm encouraging you guys.
Rick, I think you did a great job. Important recommendations. I have a
It
couple.
wasn't just me, Javier and George Washko and a whole team of other people spent time overnight putting this together.
I appreciate that, and I thank all of you. I wanted to bring forth the comment I made the other day, because Ella had brought up this important concern, and it's just a functional one, but I think if we do something here, it might have some benefit. And that is the issue about the data, the imaging data that the radiologist interacts with is evolving to be different than the imaging data that the computer vision may deal with. And working out some kind of understanding that these two sets of data can be dealt with in different ways as we do in other imaging settings, so that we're not held up by some systems insisting that a radiologist look at every pixel that comes out of the scanner. And I don't think that's a problem from your perspective. So I would just mention that. And I must say, I really enjoyed, and I think a lot of other people did as well, our keynote from Catherine Schmidt. And she talked about the evidence for how beneficial physical activity was for cancer, and potentially in this setting as well. And one of the things that we talked about somewhat then, and then came back to in several other portions of this workshop, is the idea of putting together some kind of composite of a normal health scan, of some assessment of musculature, some assessment of fat density, some assessment of other things, to try to get at health and fitness from a scan that potentially could be a one-time look, but you could also potentially look at fitness as it evolves or devolves over time. I think that would have an enormous application as we move to population health in a variety of settings, in understanding how beneficial exercise may be on an annual basis to all kinds of other things. And I think there was a lot of enthusiasm for it. I would love to see it picked up in your comments, in however appropriate, to make sure that people continue to collaborate in developing something like that. I don't know if you have any thoughts, or if George had any thoughts, because this seems to be an interesting and different opportunity.
Well, so the good news is that when we come up with recon kernels and other things, let's say resolution requirements and other things, there's a great deal of overlap between that and other, let's say, clinical applications of a high resolution CT scan. So, so we can, I think we have to keep our eye on the goal here, the main goal, which would be, let's say we focus mainly on early lung cancer and emphysema, but then keep an eye out, just like we said below, for these other diseases as well as conditions that may be useful to everyone. If I could also go back and tie it a little bit together here. You see this statement about no accepted resolution methods for anything from 100 to 200 millimeters out, or even beyond 100 is really what it should say. Well, if you're trying to measure muscle and other important characteristics out in the periphery of the lungs, it's really important that your resolution doesn't fall apart out there. So I think what we're doing, again, has a lot of overlap with let's say these new exciting things we can potentially go after in looking at muscle around the rib cage. I don't know, Javier, do you have anything to say?
Yes, yes. I think, I mean, we did try to push this concept, Jim, and I'm especially even more excited about it after I heard today's presentations. I tried to get from George and Raul, you know, to them to define a little bit more of that lung injury index that they are working with. I think that kind of thing is key for this, and I agree with you. We should be looking beyond. And yesterday we also stressed this, and maybe it's not reflected in our conclusions that well, but we did, you know, talk about not only looking at lung cancer and emphysema, but expanding it to many other things. And I think lung health is a key. And so maybe we have to, I don't know if it's that lung injury index that it's already published, and or should we come up with other standards? I don't know. I mean, that's up to you guys, the technical people. But I think there's a lot of information on the CT scan that we already see and we already know is giving us incredible information. And we should probably include that in the conclusions.
I agree.
I don't know, Jim, if a CT scan is going to be good to recommend exercise or not, but maybe we can aim for that.
All right, I think this is left to Jim to summarize what we've done here.
This is okay. Okay, so we're in the clubhouse turn. Thank you, David. Thank you, Rick, and others for your work in putting together these summaries. I think there was wonderful discussions. I think I also appreciate the extra work that all the moderators did in terms of preparing questions and sharing them with the panelists. And we had some very enriched discussions in a relatively compact period of time. And it was great to see that. It would be wonderful, and I repeat the comment before, that we would love to get feedback from people about this format, about specific topics, about specific speakers that you thought should come back to the organizing committee so that we can understand what we did right and potentially what we did wrong, so that we can do this better and more effectively in the future. So please fill out those questionnaires. And the panelists participating in this question and answer format, I think is also very challenging at some levels to prepare for that. But we had wonderful conversations. So however you did it well, and we appreciate it. I wanted to talk about next steps potentially that emerge from this that are important to kind of affirm so that we actually do them. It was wonderful to hear from Al Rizzo that he was very committed to doing a white paper regarding clinical management and implications from this integrated screening between lung cancer and COPD. I think he's going to be talking to a lot of people. If others are interested, if you contact either myself or Al directly, I'm sure he would be happy to involve others in this process. There's some other activities that he described that are really wonderful, which show the commitment of the American Lung Association to bringing forward these services in a robust way for people now. And that's just wonderful. Continues on a very positive legacy they've shown in their efforts previously on lung cancer screening as well. I want to affirm and congratulate Rick and his colleagues on their efforts to follow up on their guidance activities with COVID, with now bringing forth that core group of experts to talk about a guidance document for technical considerations in the evolution of integrated lung cancer COPD screening. I think that kind of document would be very welcomed by the field. We know that things are going to change quickly and there's going to be other perspectives and stuff like that, but to get it started, to have something out that investigators across the world can look at and think about and potentially add to, modify, refine, it would be wonderful. And it would catalyze progress as we've been discussing for the last 2 days. I wanted to stop here just to make sure that we weren't missing anything. We had a wonderful discussion from Chris Lathan with his panelists about the need for community engagement as we go forward in developing specific tools and the process for implementing screening across all the communities of the world. And we will continue to do that. Are there other things that people want to mention? Because the sand is running through the hourglass. So it's now or never. In that case, the final speaker will be Bo Aldershay. And before I disappear, I wanted to thank everyone again for participating, for asking questions, for bringing up tough points, for being gracious in sharing multidisciplinary perspectives in this complex area. And I want to thank, and I'm sure Bo will also do this too, the people who helped us bring forward this forum. And that's, I see Liz Hall's picture on this, and Adrian Harkness, who has helped us. Jody Hoyos just walked through. Bo and her unswerving commitment to this over the last almost 2 decades. This has been a labor of love because it's certainly not a financial benefit to do this type of thing in this evolving area. So thank you all very much. It's been an important effort. Everybody here has other things to do, so we are so grateful for you sharing your time with us. And let's hope we can continue this momentum and bring forward these services for the people that are afflicted by these terrible diseases. I'll stop there. Thank you very much, Bo.
Thank you, Jim. And I think I should close. Oh, I thought they'd muted me again. Anyway, I should close by starting out to thank Jim for his leadership of this whole effort for, as he said, almost 2 decades. Jim is the vision behind this workshop, and without his leadership, I don't believe we'd be sitting around this table, those few of us who are sitting around a table or seeing ourselves on a screen 18 years later. So thank you, Jim, for really taking the lead and keeping it going, keeping the fire stoked. Jim thanked Adrian Harkness and Liz Hall, and really they are the ones who keep the gears turning in between the meetings. Without them, we really would have a hard time keeping our steering committee in line and having our biweekly calls and doing all the things that have to go on between meetings to ensure that the next meeting will be even more successful than the previous meeting. Jody Hoyas has been an amazing addition to this team, and she has helped in countless ways, from technical support to finding us a writer. And that's something I would like to mention, is that we have a professional writer, a science writer, who is taking notes and will be summarizing notes so that we can distribute them about each day of the meeting. And then additionally, working behind the scenes, Lisa Berry Edwards and Sarah Mahoney, who I mentioned yesterday, does all the incredible graphics, all the slides, everything that makes it look pretty on the screen. I'd like to congratulate Mary Pasquinelli once again for her leadership and for her receiving of the James L. Mulshine Leadership Award. I think that there could not be a more deserving recipient, and we're really delighted that she was able to come to town a month ago and we could have a little awards ceremony in person. That meant a lot to all of us. I'll echo Jim's thanks to the steering committee, not only Jim, but Al and Bruce, David, Anita, all of you have just done, and Rick and Raul, excuse me, you just weren't in the room, so I almost forgot you, but I shouldn't forget you because you play a critical part in this meeting. And then, of course, Claudia, who is represented on the steering committee by her partner in crime, David, is here with us. And we're just delighted, because without her vision and leadership, I don't know that we'd be talking about CT screening for lung cancer and COPD. We really appreciate the ALA's partnership in this meeting for the second year in a row. They have been wonderful partners, and we're just delighted that we can work together to focus on both lung cancer and COPD as two of the 4 leading causes of death in this country. And I think it's really important that we've joined forces and can work together to ensure that spiral CT, that low dose CT can make a difference in reducing these unacceptably high mortality rates. I want to thank Blue Ridge Technology, and Bill, forgive me, the formal name of your company always escapes me, but our technical support, our IT, is provided by Bill Randall and Peter Conklin from Blue Ridge. And if you ever need to hire a good technical support company, they're your people. They're in Charlottesville, Virginia, in the beautiful Blue Ridge, and they have gun will travel. I'd like to mention before closing that we have been just discussing among ourselves the fact that this seems to be a really good date for this meeting, in between, it sort of threads a needle between the IASLC meetings and RSNA and the thoracic meetings. So we're just going to ask you to pencil in November 3rd and 4th of 2022. Go ahead and put it on your calendars, and we'll try to get that date confirmed, and so you can put it down in ink, and we hope you'll be back. We are very grateful to have had the participation of so many of our friends around the world, and who've been interested and have logged on to the meeting, and hopefully and really learned a lot. We are delighted to have been able to participate, our foundation, in some of your screening programs by providing the phantoms, which Rick Avila mentioned earlier in his talk. And for that reason, because I think we had 15 countries represented, we will do our best to be able to put on a hybrid meeting next year so that we can get the global participation, because this is a global issue and it's clearly so important. And the only thing we have to do is make sure we get enough sponsors. So I'll close by thanking the ALA, our partner, our gold sponsors, the Johnson & Johnson Lung Cancer Initiative and Median Technologies, and the rest of our bronze sponsors, friends of the foundation. We appreciate the endorsement of the IASLC. That meant a lot. And we'll just build back better, to use a familiar phrase. So we'll keep building, and we're just grateful to all of you for helping us come this far. Have a wonderful weekend, and I hope we'll see you next year, and I hope we'll see you a lot before that, because we're tired of Zoom. Bye-bye.